Good evening, everyone, and welcome to our webinar. Today, we will have Dr. Abdulrahman Sabbagh. He's a neurosurgeon, pediatric, and epilepsy surgeon in King Abdulaziz University Hospital in Jeddah. He's the Associate Executive Director of Training inside the Commission for Health Specialty. Thank you for joining us, Dr. Abdulrahman, in Saudi Association of Neurosurgery and SANS Academy, and to participate with our continuous education.
Jazakumullah khair. It's an honor to be with you. How many participants do we have so far?
So far, we have 113.
We should have said one. مرحبا بكم جميعا. أشكركم على إتاحة الفرصة هذه لي. I really appreciate your kind invitation to this, and I should have participated a long time ago, but unfortunately with my I'm really tied up with the Saudi Commission for Specialties, but inshallah I'll be able to talk about this topic today, and I hope I will shed some light on the neurosurgical treatment of for spasticity that we do. I think the slides, this video will be recorded, and I think you can come back to it at some point. I think some patient videos, I don't have the permission from the patients to. I should have the permission to show them, but not to upload them and keep them on the web. So you can see them now, but probably not see them in the recording. We have residents with us. I'm sure most of who we have are residents today, correct? I want you to tell me what you see. Can they participate?
Yes, they can participate in chat, and we can read their comment in from the chat.
Okay. I'm going to run these videos, and I want them to tell me what they see.
So we have one of the answers is a spastic paraparesis with scissoring gait. Another answer is a shuffling gait.
Okay.
I can see there is tiptoeing in one of the...
So let's, who said scissoring gait?
Abdulaziz Babtin.
اهلا وسهلا عبد العزيز بطل. طيب ومين كمان قال لك انت قلت لي tiptoeing, correct?
Yes.
So basically what we see here, let's go to the first image. This is this young lady, 7-year-old Saudi girl who's one of my previous patients. Basically, she showed up with spasticity, and she's known to have. So let me ask the question: what do you think caused this? What do you think caused this for the patient to happen? You have any answers?
Answer is coming. Most commonly CP, typical in CP patients.
Cerebral palsy. So what's the cause? I was going to tell you in the history.
Yeah, there is an answer from Thnayan is anoxic brain injury.
Okay.
And most likely due to the oxygen deprivation during the pregnancy.
We're going to touch upon that soon. So this young lady was born at 27 weeks of gestation and had grade 1 or 2 IVH. And then she was fine. She grew up, and then with time they realized that she's having spasticity in the lower extremity. She had delayed milestones in terms of motor, in terms of gait, but not intellectually. Intellectually, she did superb. She was doing very well as she grew up. Very intelligent young lady, doing very well at school, and continued to do well. But as you see, let's come back to the gait here. You see that she's tiptoeing. She's not able to have her heels on the floor. She cannot extend her knees fully. Her knees are bent. She's also scissoring while she walks. And as you see, she has a bit of a problem with balance as she turns. More importantly, as you see, her upper extremity rocking movement, she's swinging one side, the right side is swinging more than the left side, and she has a um, flexed elbows, correct? And not just that, she has an interesting hand posture if she's as you realize. She's always trying to look at the floor, making sure that she's walking properly. And she had because of the scissoring, she has inverted toes. This is she's an independent walker, but she has spasticity, and this spasticity is causing her a lot of trouble with the activities in daily living. This is a child that you want to help to bring back as much as possible to be able to walk on her heels, to give her better postural control, better stability while walking, as well. When they walk, the longer they walk, they start having more and more pain in the back of their knees, in their back, because they're compensating in their hips, in their shoulders, in their neck. You want to help them with that. As you also see here, when she's climbing a stairs, she's barely bringing her heel to the steps, and she's not very stable, especially when she comes down. As she has to look down, she has to know where to. She has to go on half a step each time, and then to go down. Importantly, and this is very important. I don't know if you can take off these pictures. A spastic child is not a weak child. And you have to be sure that they're strong before you embark on any kind of intervention that would make them lose their spasticity. Because some children use their spasticity as canes. Sometimes they even need their spasticity to be able to walk. So it's very important before you embark on any procedure, especially if these children are walkers. You have to be sure that not to interfere with their ability to walk and to have the activities of their daily living. This is a patient that I had at King Fahd Medical City many years ago. Okay, so what's the definition of spasticity? It's a condition where there is an abnormal increase in muscle tone or stiffness that would interfere with movement, speech, and and it may be associated with pain. And it's usually caused by a problem with the upper motor neurons. I'm going to talk about, this is just an overview. I'm going to talk about cerebral palsy, treatment options, background, patient selection, surgical approaches, SDR, the selective dorsal rhizotomy, which is a procedure that is not done often. And I just want to take this opportunity to shed some light on it because it's not something that we see often enough. We're going to talk about neurophysiologic techniques used in that, and we'll talk about outcomes and complications. And at the end, I'm going to show you some videos of befores and afters. So this is a condition that consists of many abnormalities that result from injury to the central nervous system, mainly the brain in the pediatric population, the spinal cord in the older population. It's about, the prevalence is about 500,000 patients, about 9,000 patients annually in the States alone. And the number is actually bigger, especially in developing countries, especially when you have problems with the ability to take care of premature babies. 5 subtypes that we talk about in spasticity. It's one of the commonest is having a child born prematurely. More than 80% of cerebral palsy patients would acquire the condition prenatally because of extreme sensitivity to oxygen deprivation of the white matter located near the lateral ventricles. And I'm going to show you a picture of that. During the 26th, 24th weeks of gestation, during or after delivery. Especially when patients have premature delivery, especially if they have IVH. And especially when the weight is below 1.5 kilos. Let me just So as we said, especially with children at birth weight of below 1.5 kilos, they're associated with brain hyperperfusion. And that may lead to periventricular leukomalacia, as I'm going to show you later, and German matrix hemorrhage. Let's move. So cerebral palsy and diplegia. So in children who have cerebral palsy that eventually develop diplegic spasticity, these children have a normal, almost normal life expectancy. As you see here, 95% of the children would live up to 30 years. And overall survival of all patients with cerebral palsy up to 20 years is about 90%. So let me just go, all of you know the muscle, muscle spindle. If the muscle would contract because of a reflex, the reflex arc, muscle spindle would fire, you'll sensory, and then motor will cause the muscle to contract. Corticospinal tract also would be this the voluntary movement, but you also have to remember that there's a net inhibition that happens during in a normal person. So because of the net inhibition that you have, your reflexes are somewhat timid and they're not very strong. What happens if you have a upper motor neuron lesion? If you lose both, you can have paralysis and loss of inhibition, or if that's such as in spinal cord injury. If you have a cortical problem, such as in cerebral palsy in young because of the prematurity or German matrix hemorrhage, you just lose the inhibition. And if you lose the inhibition, any impulse coming from muscle spindles will actually cause the muscles to contract further than they should be. And that's more or less the reason for spasticity. So why in the lower extremities more than the lower extremity? As you see here, periventricular leukomalacia are closer to the ventricles, and here they're affecting the fibers, the corticospinal tract going to the fibers going to the lower extremities. The foot area is more in the mesial area. So this is periventricular leukomalacia, as you see. So the fibers closer to the sensory and motor fibers that are closer to the ventricular area are the ones that are mostly affected. And you will ask, why would you have the spasticity? Why would you have flexion at the knees, scissoring at the hips, and tiptoeing? It's just because these muscles are inherently stronger than the opposing muscles. So knee flexion is stronger than knee extension overall. Also, adduction is more than abduction. And tiptoeing, the dorsiflexion is stronger than plantar flexion. You need your dorsiflexion to climb stairs. You don't need the plantar flexion except for just to carry your foot up. So in general, when spasticity would happen, this would affect the lower extremities in that fashion: adduction more than abduction, knee flexion more than knee extension, dorsiflexion more than plantar flexion. On the other hand, in the upper extremities, you know that your biceps is stronger than your triceps. And generally, when there is upper spasticity in the upper extremities, as you saw in that little girl, she was flexing her elbows, both sides, and also clenching her hand. The finger flexors are stronger than the finger extensors. And that's why you have clenched hand when a person has spasticity in the upper extremity. As you see here, most commonly involves muscles of the lower extremities, since the motor nerve fibers innervating the lower extremities travel closer to the proximity to the ventricles than the upper extremities. So what's the Ashworth scale? I think we have some of the audiences from our colleagues in the rehabilitation and physical medicine. I have a lot of colleagues from that side of the world, and these are slides helped me. The one who helped me with is Dr. Anas Saleh, one of the PM&R physicians at the Prince Sultan city for humanitarian مدينة الأمير سلطان للخدمات الإنسانية. So who's Ashworth in the 60s published his scale to try to grade spasticity while working with multiple sclerosis patients. Late 80s, this Ashworth scale was actually modified to add the 1+ to the scale to increase the sensitivity. The main problem with the Ashworth scale, which is actually the most used scale to look at spasticity worldwide, is there is a poor inter-rater reliability. The way you would say something maybe would be different from someone else. So what is the Ashworth scale? 0, there's no increase in muscle tone. 1, there's a slight increase in muscle tone with a catch and release or minimal resistance at the end of the range of motion when an affected part is involved in flexion or extension. 1+, slight increase as opposed to marked increase. Slight increase in muscle tone manifested as a catch followed by minimal resistance through the remainder of the range of motion. 2, a marked increase as opposed to slight increase in muscle tone throughout the muscle range of motion, but the affected part are still easily moved. Ashworth scale 3 considered considerable increase in muscle tone, and when you try to do passive movement, they're difficult. Ashworth 4, you have rigid extremity, inflection, or extension that is very, very difficult to move. So that's basically it. No increased tone, slight increased tone with a catch, a marked increase the muscle tone throughout the range of motion, but still you can move it, a considerable increase, and almost inability to change from flexion or extension. The PM&R physician, this is the part that Dr. Anas Saleh helped me with. They like to use the Tardieu scale. The Tardieu scale has a little bit of a difference in it. The principles, the grade is always performed on muscles that at rest before the stretch maneuver. So first you do a passive examination. At a reproducible velocity of stretch, once in fast velocity is selected for a muscle, it remains the same for all subsequent tests. So you use the same velocity. You try to do it in the same time of day because patients do fatigue. They do change if they're just waking up. Spasticity does increase when patients are tense or tired or having a fever, for example, or it's a different time if they're tired or excited. In a constant body position for any given limb, other joints, particularly the neck, should remain constant throughout the examination. Velocity of stretch, you have V1, V2, V3. V1 is slow, V2 and V3 are fast. V2 as opposed to V3, the speed of the limb falling under gravity, V3 as fast as possible. I'm going to give you the slides. I'm not going to go through it, but as you see, so the nice thing about the Tardieu scale, it's actually more reproducible and much more reliable. This is a study that showed that it's a very reliable scale as opposed to Ashworth, but because it's a more complicated scale to use, it's not as often used as the Ashworth scale. Every neurosurgeon knows the Ashworth. This is just a picture showing you, it comes from the European Consensus in 2009. They looked at different levels of GMFM scores and what kind of treatment you use. So here they're talking about, for example, patients that are very, very dependent, GMFM CS level 5, they will probably use all kinds of procedures such as the functional therapies, orthosis and aids, medications, Botox injections, intrathecal Baclofen, as well as orthopedic surgeries for tendon releases and what. And as the higher you go, for example, these patients, the GMFM level 1 And level 2, you have less and less, for example, orthosis and aids. For example, these patients, such as the young girl, she's between 1 and 2. She would, when she goes to school, she takes a walker, but at home she does not need a walker. She's between that, and then she's basically doing physiotherapy, and you know, she was proposed for intrathecal baclofen, but for her we did something kind of different. And she did not have any orthopedic surgery to begin with. Later, she had a small tendon release on both ankles. So this is from a study in 97. I don't know why the reference didn't come. They basically tried to explore all the surgical techniques used in spasticity. So stereotactic encephalotomy is something basically doing globus pallidotomy, doing, as well as you know, stimulation. Some people are proposing that. The results are not that great. Neither also cerebellar stimulation. It's something that was proposed and not really that great. Now, some people propose longitudinal myelotomy in the cord, in the cornus medullaris, and that has its own set of complications, and this is not something that people do as much. Maybe some people propose it for very, very spastic children. Cervical rhizotomy for upper extremity is potentially useful, but it's something more or less abandoned recently. Selective dorsal rhizotomy, this is something that is very unique and it's very helpful, but the problem with it, it needs a very heavy multidisciplinary approach. It's something that I used to do in King Medical City with a lot of difficulty, but once we did it, it was very useful for children. I'm going to show you some videos. And I'm hoping that we come back to doing some more, because there's a big subset of population that would really benefit from selective dorsal rhizotomy. Neurectomy, it's very variable, and the problem is there is recurrence. And the major problem with it is permanent painful dysesthesias. Tendon lengthening and releases, it's something variable and generally effective, and used for contracted muscles. And this is something that's very commonly done by some of the orthopedic surgeons that are involved with spasticity. So drugs, as a resident, you need to know what baclofen is and some dosing and how it works. It's basically, it binds with the GABA B receptors in the brain. It's an agonist. It restricts calcium influx into the presynaptic nerve terminals, thereby reducing spasticity. It's a GABA receptor agonist. Tizanidine, it's a centrally acting alpha-2 adrenergic agonist that is also used as an anti-spastic. Dantrolene, it has no effect on neuromuscular transmission. On the other hand, it works directly on the skeletal muscles. It hinders the release of calcium from synaptic reticulum, sacroplasmic reticulum, and thereby it prevents excitation and contraction coupling mechanisms. It also can be used in other problems such as malignant hyperthermia. So what's the pain? What's the point of what's the main objective behind treating spasticity? You want to relieve pain and discomfort. You want to improve the posture. You want to facilitate sitting, standing, and walking. You want to reduce the burden of care by the caregivers. You want to improve hygiene in areas of the palms, axilla, and the groin. And one of the main problems, if you see these, you know, the level 4, level 5 spastic children, the main problem, the mother will come to you and tell you, I cannot change the diapers of this child. It's a major problem trying to take care of them, trying to put on and take off their clothes. As well, you want to improve the body image and self-esteem, especially that, as you see, many of the cerebral palsy children have normal intellect and normal cognition. They go to school, and they always feel that, you know, other children will bully them. Other children will, they always get a stigma because of what they look like and how they walk and how they talk. You also want to prevent problems such as pressure ulcers and the like. These are some options that we discussed: medication, Botox, Baclofen, orthopedic surgeries, selective rhizotomy. OT and PT are main, and I also should add speech therapy, because many of these children have slurred dysarthria, and they speak slowly, and they at school they get bullied just because they can't articulate their words easily. This is just a slide that you can use to look at the dosage. Botox, it's a snare protein cleaver that would prevent acetylcholine from leaving the nerve into the synaptic area, and this would hence lead to a paralysis. We kind of talked about that, but the main here we're going to talk about the Baclofen pumps. And the main objective between when you put Baclofen pumps is to reduce pain, improve mobility in some patients, improve spasticity, and improve sleep. So the drug delivery system, I'm sure some of you, most of the senior residents have seen it. It's a catheter. Most of you have seen Baclofen pumps. I'm not sure if all of you have seen the complications. Complications from Baclofen pump are not uncommon. They're pretty common. As you see, catheter breaks, dislodgements, kinks, they're about 5 to 15%. Infections, about 4 to 40% sometimes. Cerebrospinal fluid leakage, 2 to 8%. Pocket seromas, and the rest of it, constipation, nausea, vomiting, headaches, increased oral secretions, low extremity DVT, ulcers, hypotonia. These are things, maybe ulcers not as much, but these are things that are does not make Baclofen pump an easy process to deal with. And especially, it's a very expensive device. As I recall, when I was in King Fahd Medical City, in about 4 years between me and Dr. Maqsood, we've done about 60 pumps. Out of these 60 pumps, 9 had to be removed because of complications. So imagine the financial burden on the institution. Imagine the problems for the patients. Also, the problem with Baclofen pump is withdrawal. One of the problems is you have to be sure, definitely, that the patient would be back for refill before the pump is finished. Because if there's if the Baclofen is finished, to begin with, patients have increased spasticity, itching, agitation, but then severe withdrawal can present with psychosis, hyperthermia, dyskinesia, and potentially neuroleptic malignant syndrome, and potentially death. What's the treatment? Baclofen. Benzos. If the patient, if you don't have Baclofen ready, you can give benzodiazepines. And surgical correction of the problem. If the problem is not just the pump finished, maybe the pump is not working, you just change the pump, or change the catheter, or connect the disconnection. These are pumps. As you see, this is that's the pump. That's a Synchromed 2. And this is where you fill the pump. This is where you test the pump. And here is the connection to the tube. That's the pump here. And as you see, that's the connection. And it's not very clear, but the tube is reaching up to here. That's the tube in the back. This is a patient with a dislodged pump. I had one of my patients, I remember one of the first few patients that we've done, and this is a main problem that you have to think about. Do not do surgery on patients that would leave the area that you work at, because the problem is, I had a very similar patient where he went to I done it in Riyadh. He went to the south, and then one time he was happy. He's walking up the stairs, and he fell on the stairs. He cut the skin on the pump. It took him 3 days to arrive to the hospital in Riyadh, and by the time we could have done something, it's already infected. We had to remove everything, and then we'd have to, wait for another few months before he's ready for another pump, and then he goes to the bottom of the list of trying to wait for another pump to be given. So it's not a very easy thing to do. On the other hand, pumps, I don't know, some of the slides have been deleted, field indications, and okay, we'll talk about it later. But generally, they do very well when patients, especially with very spastic children, smaller children that are very spastic, we like to they do respond well, and the parents are able to give them care. Children who are on walkers, or adults especially on walkers, they are able to walk better. Uh, with spinal cord injury, when in the adults with spinal cord injury with severe spasticity, they do respond well. Unfortunately, I don't know I don't know where my slides have gone, but I had some functional scores that show that there is improvement. But the problem with pumps, as I said, they have their own set of complications, and they're very expensive, and not all insurance companies would care for them. I don't know how it works now with how things are changing. I don't know if insurance will cover it. We'll see. I'll move on to selective dorsal rhizotomy. Maybe I took a little too much time, so I'll go a little faster. Sherrington, when he did the dorsal rhizotomy for cats, he realized that there's a reduction in the inhibitory signals coming from the motor nerves, and that gave them looser lower extremities. Abb and Bennett were the first to do it on humans. Forster actually sectioned all sensory nerve in the lower extremity for the lower extremity, and that led to, very nice improvement in the spasticity, but that caused severe muscular weakness and complete loss of skin sensation and proprioception. Other people improved it. Mainly Peacock from South Africa and Aarons are the people that really established the criteria and did the first successful group of patients. So it's basically, as I said, for selective dorsal rhizotomy, SDR, you have to know what kind of patients that you want to do in the cerebral palsy population. And you have to know that the results are permanent. And why selective? Because you want to selectively interrupt those afferent limb, the afferent limb of the reflex arc, and not just doing it, randomly. People at first they did the dorsal rhizotomy. They just take half of the sensory nerve, cut it, and then they move on. But doing more of a selective fashion, I'll explain to you how it actually does make sense. Again, just like in Baclofen pump, the selection criteria are very similar, but you have to be very careful how you select your patients. Not everyone is a candidate for rhizotomy, and not everyone is a candidate for Baclofen pump. Let me just mention Baclofen pump here because somehow I lost the slides. Baclofen pump, the selection criteria, once a patient is doomed to have severe spasticity or whatever level of spasticity, you will have to do a Baclofen test. These patients will have go under lumbar puncture and will be injected with Baclofen, and then would be examined before injection of the Baclofen intrathecally, and then examined after over a sequential examination by the physiotherapist. And as you see improvement in their Ashworth's score and their GMFM, you can decide which patients are going to go for Baclofen pump versus those that should not respond to Baclofen pump. And if patients respond to oral Baclofen without having complications, then maybe they're not a candidate for Baclofen pump. But if they don't respond to Baclofen pump, because Baclofen intrathecally is 1,000 times more potent, so you can give a very, very much smaller dose than you can give it orally in the thecal area, and that would give a good response. You also have to choose patients that have enough skin and enough weight. We don't generally put a pump in a patient that less than 10 kilos of weight. Some people say 20 pounds of weight. Because the smaller the babies, the smaller the children, the more prone they are to skin dehiscence and problems, especially that these pumps are big. There are smaller pumps, but the smaller the pump, the smaller the amount of medication. Anyway, coming back to the selective dorsal rhizotomy, and I hope that this is something that we can come back to in Saudi Arabia. Um, you have to select your patients well. And the best candidates are those between 4 and 9 years of age that are walkers, independent walkers, or walkers with walkers. Basically, what you want to do is select the dorsal roots that are giving the worst reflexes upon your intraoperative stimulation, and those are the ones that you cut. Hence, giving less abnormal sensory feedback from the spindles, fibers, hence giving less stimulation to the, or less spasticity. So this is how the SDR community had classified the preoperative function of spastic children. Group 1 walks without assistive device. Group 2 walks with assistive mobility device, such as a cane or a walker. Group 3 are quadrupeds, they crawl. Group 4 are commando crawlers that are wheelchair bound. And group 5, no locomotive abilities. They're fully dependent. So selective dorsal rhizotomy, when it was first proposed, it was given basically group 1 to be able to have better appearance and effectively walk better without assistance. Group 2 to hopefully decrease the requirement of a walker or a cane. Group 3, improve the ability to move and hopefully, instead of crawling, to be able to walk with assistive device. Group 4, short term, to ease of taking care of the child, such as also the same for group 5. But in reality, no one does group 3, 4, and 5. At least 4 and 5, they're not really surgical candidates. They're not really selective dorsal rhizotomy candidates. It took me and Dr. Al-Banyan about 5 years in order to do the first case in King Fahd Medical City. Despite having a hospital, a grand, institution, King Fahd Medical City has a full, rehabilitation institution. We tried to buy the electrodes, we could not find them, so we had to make our own. There's a Sabbagh Banyan, Reem Al-Banyan, so Sabbagh Banyan dissecting rhizotomy electrodes made by Inomed. And at the end, we were able to group everybody to get these surgeries done. Dr. Ahmed Abu Abat is really someone to thank for. Shara Al-Atabi is a physiotherapist that helped us with all these patients. Dr. Reem Al-Banyan, who helped the neurophysiologic monitoring and actually developed the equipment. Dr. Tariq Imtiaz, Dr. Al-Banyan for sure, and myself. We were a team that did this case. And we learned it from the Montreal Journal's approach developed by Jean-Pierre Farmer. So basically, I don't want to go very much in the patient selection. We talked about that quickly. But generally, you'd have a velocity-dependent spasticity, hyperactive reflexes, if you reduce range of motion, and you have to be clear on what your goals are. Patients have to have no psychological problems. They're mature and they're able to do with you. We use the GMFM, PD, and PBOY evaluation, urodynamic studies, and gait analysis. So it's a major undertaking. And you have to be very careful who you select, and I 3 to 7 age of, I went up to 9 years of age, but beyond that, the effect is not very good. In the contraindications, dystonia, rigidity, severe damage to basal ganglia, fixed joints, or scoliosis. Hydrocephalus is not really a contraindication. Cognitive delay is bad. Older age, also you have to be very careful. So I'll just go quickly. This is a picture of how you set up your operating room. You have the two surgeons, this is Dr. Banyan, myself, this Shara Al-Atabi doing a physiotherapy. She's actually, and you see transparent drapes because we're stimulating each. These are the Sabbagh Banyan electrodes. That's Dr. Imtiaz, the neurophysiologist. Basically, it's a group effort to try to select each of the nerves that are actually causing the abnormal reflexes. You see, this is the patient here, physiotherapist, anesthetist, the neurophysiologist, and the nurse, and the two surgeons. That's the picture. If you open the S2, this is a caudal, this is rostral, but basically you open from L2 to S2, and you take out your nerve roots, and as you see, the sensory nerve roots are different from the motor roots. They by themselves they start. You can see that you can open them from each other, and then you can select each one of them by stimulating it. And as you see, this is the the electrode. That's just a slide from our publication from Dr. Imtiaz. So L2 to S1, as you see here, this is how you open, and you do your neurophysiologic monitoring, and this is the Sabbagh Banyan electrode, and it's not very clear, but you take out each nerve root and you do your stimulation. As you see, taking one sensory nerve root here, that's the L4 probably, and make it into fascicles. That's one fascicle, and we'll stimulate. So that's one electrode, that's the cathode and anode, and we stimulate and then get the result. And the results being the physiotherapist is actually examining the reflexes. The neurophysiologist is actually looking at his let me just, these are the kinds of reflexes that the responses, and you want to cut the nerve roots that would give you bad responses. For example, you stimulate the L4 and you get reflexes in the upper extremity. So that's something you want to, for sure you want to cut, but something that would give you a normal response, then that you don't cut. So that's a S2 dorsal. You see the gastroc. This is a response grade 1 and grade 2 from right S2 and right L3. That's a worst response. That's a grade 3 or grade 4 response. You see, you give one stimulus and you have both right and left being stimulated. So that's basically, just gonna go through it. You see, as you open fascicles between the nerve roots and you cut the nerve roots that are affected. Let me just go through this. So basically, patients feel an instant reduction of spasticity. The first few days after surgery, the patients feel extremely weak. But then slowly after the first week with physiotherapy and rehabilitation, they slowly would improve. I think I'm taking too long because we need to leave time for questions. Complications, it's a generally safe procedure, but they have transient dysesthesias, numbness, transient urinary retention, back pain, headache, and CSF leak. That's one issue that we have to look at. Infections, bronchospasm, CSF leak, hemorrhage, spinal deformities, they do happen with time because we open, as you see, a large opening. This is a procedure as opposed to the Park procedure. Park does only one level laminotomy, and then using the stimulation, he would locate the nerve roots. But the problem is, that these nerve roots they give abnormal responses. It's very difficult to do it just by one level. But although he has published his results and he has a very large series, I do respect his way. I tried his way to begin with, me and Dr. Banyan, but then we resorted back to the large opening. This is just showing you GMFM total score. They do improve, group 1, group 2, group 3. They always improve with time. So after 5 years, they're better than they were in 3 years, they're better than they were in 1 year. They continue to, and there's also another study that up to 15 years, and they continue to improve. So early complications, we talked about that, and late complications, we also touched upon it. So this is just the paper that we recently published on that. Let me show you some videos. This is a preoperatively. As you see, this is a group 1. And you can see that he has some toe walking, and but the scissoring is not very bad. He's kind of slow, and he tends to fall, but he's okay. This is 1 year postoperatively. As I said, they continue to improve, but here now, as you see, he is faster. His heels are touching the floors more, and he's able to run faster, and his stability is better. But when he runs faster, he tends to actually walk on his toes. This is another patient. This is the same patient walking backwards. You see, he's not bad. He's a grade 1. He's a level 1, a group 1. And here, after the surgery, 1 year postoperatively, you see the heels are touching the floor each time, and his stability is somewhat better. That's okay. So this is another patient. You see. You see, very bad that the toe walking, and the scissoring is pretty obvious. And he's, you know, swinging on both sides. You see, and his hand swing is pretty strong. This is 6 months postoperatively. The hand swings are more normal, and now his heels are reaching the floor better, and his speed is more stable. This is another patient. This is actually the same patient climbing the stairs. This is preoperatively. You see, he's scared when he's walking downwards, and the scissoring is also preventing him from coming down easily. Here he's climbing better. But now he's more careful, and as you see, he's looking away. He's not looking to the floor. He's actually more comfortable walking down. You see, as he walked down here, he's always looking to the steps. He's worried that he's going to miss the step. Here, when he's walking down, he just looked once, and then he's looking away. He's not always looking down. So he's more comfortable and more steady as he comes down. This is so basically she's sitting to squat to stand. She's not to stabilize herself when she stands. And here we're basically trying to ask her to do squat to stand, and it's very difficult for her to stabilize herself. Here, 6 months after, it took her some time, but when she stood up, now she's able to stand without support, and her movement is not bad. Climbing stairs. Before and after. This child is a group 2 because she uses a walker. The steadiness is more or less, as you see her, she's not bending her knees as much. The same girl we saw at the beginning, she was running, she's having trouble. Now her walking is somewhat better. Before, she always used the walker. Afterwards, she uses one cane or no walker at all at school. She takes a cane with her at school to try to prevent from falling and having trouble. Okay, so basically here, in summary, we've gone through an array of surgical treatments for spasticity. We mainly focused on how do you do that? I don't know. Anyway, so we mainly focused on Baclofen pump and selective dorsal rhizotomy. For some reason, I don't know where my indications for Baclofen pump and the pump test is gone, but it's okay. It's just we can talk about it as we speak now. So if you have any questions or anything I want to discuss, I'm willing.
Thank you very much, Dr. Abdulrahman. We will receive the questions in the chat, and the first one, what's your protocol for post-op pain management and what kind of rehabilitation you're aiming for?
This is not from a neurosurgeon, right? This is from a PMNR physician?
Yeah. This is Babtin. It's a neurosurgery resident in.
Okay. So this is again, this is a multidisciplinary, an interdisciplinary approach. This the, they do have a lot of pain. So benzodiazepines, because of the first 24 hours actually after selective dorsal rhizotomy, sometimes they have reflex hypertonia, and then hypertonia, and they get into a lot of pain in the lower extremities. So benzodiazepines are given, as well as whatever is a protocol that we have. For example, we give the IV paracetamol, as well as morphine. In the first 2 days, we have the short, small doses of morphine that are given PRN. And usually these patients will do well. For a Baclofen pump, it's not painful. And then for me, I used to keep them 1 day in the floor, just not to get into trouble. It's not a painful procedure. It's almost a day procedure that they can go home the same day, or they can go the day after. SDR, no, they stay in the hospital for about 1 week, and then beyond that, they would have to go as an inpatient rehabilitation. For inpatient rehabilitation for about 4 to 6 weeks. That's why it's a very hefty procedure and requires a lot of interdisciplinary approach. But then in the long run, you don't need to refill the pumps. You don't need to get into trouble or complications from the pump site and the rest of it. So it's one big shot, but in the long run, it's cheaper than the Baclofen pump. Baclofen is extremely expensive. The pump is extremely expensive. And to change the pump every 5 years, 5 to 7 years, is also very expensive. And the problem is the patients are very dependent on the institution, the hospital. They have to come back and forth. And if God forbid, for whatever reason, there's no money to pay for a pump, or the Baclofen is out, it's a big problem. And I'm sure our friends from PM&R have faced that in the past.
We have a question about how does the age affect the outcome of SDR, selective dorsal rhizotomy?
So when Peacock first did it, they did patients up to 15, 20 years of age. But for some reason, with maturity, with plasticity is much less as you go beyond 7 to 8 years of age. It's just that the group from Montreal, when they studied their first group, and actually the group in New York, Abbott, they studied their first group. They realized that patients that are younger than 8 years of age, they do much better than those that are above. Still, Peacock in South Africa, they do patients that are older, especially that they use the procedure even for group 4s, because again, pump is very expensive. So they use it for even more spastic children, to give in order not to use a pump. Although for group 4s and group 5s, the very spastic children, SDR is not as good as Baclofen pumps.
We used to have a lot of patients in our institute in King Faisal with the Baclofen pump with Dr. Ahmed Al-Khani and Dr. Faisal Al-Tabi, and we can see that we saw a lot of complication. Just to give our colleagues the difference between the Baclofen withdrawal and Baclofen overdose. How can we differentiate between both symptoms of patient present to the emergency department?
Can you go again, difference between
Baclofen withdrawal symptoms and overdose?
So withdrawal, I deleted some of the slides, but withdrawal basically is when patients are going to be very spastic, and they may have hyperthermia. They will have psychological changes. Overdose, they are very, very weak, very loose. And then actually overdose can actually give them bradyapnea and other problems. It's very clear. You can clearly differentiate between them.
We pass with 2 patients, one with withdrawal and one with overdose, and both they ended up in an ICU admission for a period.
Yes. Yes, yes.
for recovery.
Now, I had one patient. We thought he was a withdrawal, and he'd had he he was becoming more spastic, and we didn't know why. The pump was good and everything, and then eventually he started developing a fever, and he actually was developing a meningitis, and that was the reason. And then we had to remove the pump and then replace it, and it's another problem. But so meningitis can sometimes fool you, especially if it's a low-grade infection.
There is a multiple question, but we will pick two and we will conclude our webinar. We have a question about selective tibial nerve dorsotomy. Did you have any experience in that, and what is the success rate in this?
Okay, I never did any neurotomies. I've never. I think Dr. Addas, he's our famous peripheral nerve surgeon. He may have had experience with that, but in general, neurotomies sometimes they cause severe. From my reading, I mean, they cause severe dysesthesias. Sometimes they don't really. Their effect is temporary when it comes to. Yes, there is a loosening, but then eventually you'll have other problems causing the muscles to become rigid, and the pain is intolerable in some patients.
Is there any difference in management of spasticity based on the cause? For example, a head trauma is different than a CB patient in general?
Again, it depends what your objective is. Now, let's say someone who has a head injury, an older patient, an adult, I mean, when I talk about pediatric, because as a pediatric neurosurgeon, I talk pediatric or non-pediatric. So an adult patient who has a head injury and develops spasticity versus someone who has a spinal cord injury who develops also spasticity. All what you need to understand is what is your objective. If your objective is to give him to help his spasticity, you do your Baclofen pump, your Baclofen test. If the test works, you just do it, regardless, because it works in any kind of spasticity. I'm not talking about rigidity. We're talking about spasticity because of an upper motor neuron lesion, regardless. If it's multiple sclerosis, if it's ALS, if it's brain trauma, if it's spinal cord injury, if it's a stroke, regardless of the reason, if it is a spasticity that responds to Baclofen test, then you can consider doing the Baclofen pump test, not Baclofen pump.
Thank you very much, Dr. Abdulrahman. Really an informative lecture, and we did not encounter it frequently in our teaching. I would like to thank you for joining our webinar, and we hope to see you in the future in the coming webinars. As usual, your talk is an excellent talk, Dr. Abdulrahman. Thank you very
much. And I'm willing to take questions later if anyone wants to send me, but you can share my email. And I appreciate the chance to be with you today. And we'll see you soon, inshallah. Hopefully in another talk. You got me intrigued.
Thank you very much. Thank you very much, all attendees to join us. And